TopMedTalk.
I'm Desiree, Chappell, your host, and I'm joined by my co-host, Monty. Hello, Monty.
Desiree, great to see you. Great to be here.
2022, 25th anniversary of EBPOM.
25th anniversary of EBPOM. So, 25 years ago. First time we've actually done it here. For those of you who can't see us at the moment, we're in Lecture Theatre 1, the much-loved Lecture Theatre 1 at University College London. A place that makes some people in the room smile and some people cry. But there we go. But welcome to UCL. 25th EBPOM, first time, although it's been run by, effectively, UCL with partners for those 25 years. This is the first time we've come in-house, because it's the first time back to have a live meeting. And we have a great audience here, packed room, and we're now going to demonstrate, despite masks and social distancing, how enthusiastic they are to be here.
That was not fake. That was not a button that we pushed.
That was not a button.
We have real people in the room. We do want to give a shout out to everyone who is listening at home or wherever you are in the world. We know we have a global audience right now. Hundreds of people have joined us just for this session today. So thank you to everyone. We know we have some friends out there. Monty, today is our TopMedTalks Talks 2 sponsored session today.
And today's session, so without the sponsorship, generous sponsorship from a number of industry partners, we couldn't make everything we do free and open access. And by that, I mean the podcast. I know those people in the room appear to have paid for a ticket, thank you. But that's to help enable that everybody around the world can listen to these podcasts. It is completely free, open access medical education, which is one of the reasons I think it's been so popular. So today it's a big shout out to us from GE Healthcare, who have one of our sponsors for EBPOM 2022.
That's right. And without further ado, we want to introduce our guest today, Dr. Sadia Khan. She is a consultant cardiologist at the West Middlesex University Hospital, which is part of the Chelsea and Westminster Trust. Sadia, thank you so much for joining us.
Thank you for having me to continue the rugby things. I started off today in Hounslow, which isn't as far as most of you have come.
Well, Sadia, thank you so much for joining us. Now, we talked a little bit about where you're from, but tell us just a little bit more about yourself and your practice.
I'm a consultant cardiologist, so I feel a little bit fish out of water in an anaesthesia conference. But I'm delighted to be here and to give you a bit of background as to how I came to be interested in this space. So I was talking to Desiree earlier about my personal career journey as a consultant. So I thought, as an ST7 equivalent in cardiology, that I was interested in interventional cardiology. And then along came 2 children, and suddenly I was non-interventional cardiologist, which is great. I haven't regretted that choice for one moment. But suddenly I was interested in all sorts of areas of work that I'd never been involved in as a cardiology junior. And one of those things was handover and deteriorating patients. So I've been working in the field of how do you detect people on the general wards who are failing to respond to treatment, who are deteriorating in front of us whilst they're on our ward bed bases for about 8 or 9 years now. So that's the background of the work that I've been doing.
And we were chatting beforehand about some of your recent experiences. Now, to be respectful to the fact we're at University College London at the moment, for those of people who don't know, there are other universities available. You had been evaluating a device, a spin-out from Imperial College London, one of our great partners in London.
Absolutely. So there are indeed other universities in London, although perhaps not quite as far central as this one. And one of those is Imperial College London. And that's the sort of college university that covers the part of London that I work in. That's an engineering college, and one of the things that often comes out of there is technologies that may have a translational use in medicine. So we'd started to evaluate a patch that had been developed there. If I describe that patch to you, it's a small, lightweight patch, about 15 centimetres across by 5 centimetres wide, and it sticks onto the chest with 2 ECG dots, cardiology theme coming through here. It's got respiratory rate that it measures within it, heart rate, and a temperature probe that goes under the axilla. So we were interested in looking to see whether such technologies could improve outcomes for patients on our ward bed bases. I'd started doing this work around about 2014, 2015, and then this minor little thing called COVID got in the way, which really impacted the work that we were doing, but really made it clear that digital technologies under times of staffing crisis could really make a difference, not only to patients, but also to the staff who work on our general wards, who, to be honest, probably bore the biggest brunt of the COVID pandemic for us as an institution. And I would guess that's mirrored across healthcare systems, not only across the wider NHS, but across the world. But one of the things that this patch was lacking was oxygen saturations. And the other thing that we were concerned about is the ability to measure respiratory rate accurately. If anyone's ever seen ward obs charts, particularly when they existed on paper, you'll probably know that the most common respiratory rate that's ever recorded is about 16. And that's to do with the way that we measure and also how we're taught to measure, but it may not actually be what really is going on for that patient. So I was interested in technologies that moved beyond the patch that we were using, that probably had a different way of measuring respiratory rate. So the GE product that I've been using is in a research and a testing strategy has 2 channels. It's got an abdominal sensor as well as a chest wall sensor. And also the other huge advantage was that we had a SATS probe that was part of it.
So there's been an explosion in remote monitoring. I mean, probably most of us have got remote monitor with us, even if we know it or not at the moment. Just a show of hands, which is not a great radio gag, but we'll explain it in a second. A show of hands for people who've got ongoing experience in the healthcare environment of so-called wearables and remote monitoring. To see, there is a minority of hands have gone up. So, I mean, obviously, an obvious thing for us to want to do would be remote monitoring. And we can see that be useful, and there has been a massive explosion. Is this the first device you've evaluated, the patch, and when we go on to talk about the GE device? Those are your first 2 experiences of remote monitoring?
We've done quite a lot of remote monitoring in the community as well, but obviously not necessarily continuous data, not in the same way. So I've been fortunate enough to have experience across a number of healthcare pathways in both the acute and the chronic setting. And a lot of the lessons that we've learned are actually translatable across all of the settings that we work in. And I think if you look at the NHS strategy at the moment for virtual wards, it clearly plays into that.
So we're here today specifically now to discuss the specific GE device, which has been launched relatively recently. We've been involved, we virtually met at the first launch of the device, which is approved in Europe. And we were at the launch of the European Society recently of the GE device. And what they appear, you can tell us your personal experience at the moment, to have brought to bear, is the fact that it is wireless.
Yes.
So it is, and we'll talk about how it achieves that in a second. It's the things stick on well and stay there.
They do indeed.
Which we'll go back to in a second. And they've come up with a clever way, we're told, of managing alarm fatigue. So having some sort of hierarchical, clever components of it, which means you're not getting pestered the whole time until it gets really important. So pick, if you would ask which variables it measures, then we'll start to pick those components apart. So what does the GE thing look like, and what does it measure?
So it's exactly as you've said, Monty. So it measures heart rate, it measures respiratory rate, and as I've mentioned, it's got a novel way of doing that, which we've seen in practice is more reliable and more accurate for the patient cohort that we were using it on. It's got a SATS probe, it's got a heart rate monitor.
And you put it on and it stays on?
They do, and our patients can be mobile and ambulant, which is the other huge advantage.
Well, that was what I was going to ask. You know, when you're doing any kind of remote monitoring or monitoring at bedside, if someone goes to brush their hair or their teeth or use the restroom, your sat probe's going to go crazy, your electrodes are probably popping off. You don't see that as much with this.
No. So as a cardiologist, one of the things I was taught very early as a registrar was the toothbrush rhythm. So before we had smart ECG determination algorithms on our ECG machines, the thing to always watch out for was what looked like VF because the patient was brushing their teeth. So I'm very familiar with the idea of data and signals and noises and all that sort of stuff. Lots of noises on coronary care units like ITU.
Now, the wireless bit, the way it was explained to me, is it uses something that we think is like Bluetooth, but it's not Bluetooth. It's coded in a different way, but it allows wireless, secure communication within a hospital environment. And the problem experts have looked at this and they've said, check, that's okay, crack on.
So from my perspective, I know very little about these sorts of things. I'll freely confess that, but I'll tell you that it passed the IT department of the trust, which, as most of you, or any of you who work in the NHS will know, that's not a small undertaking.
Any hospital around the world, probably.
Yeah, so that's not a small undertaking. So if it convinces them, I'm good with that.
And that's interesting. It obviously attracted quite a lot of attention because what we want is that secure wireless communication. And as lots more people get into this space and enable it, the more confident we'll be that we can communicate safely and wirelessly. And this is a check so far. It's approved in Europe. We can use it clinically. That one's a check.
And just to add a bit of complexity onto our situation, so the hospital where we are near Twickenham, the other close thing to us that most people will know about is Heathrow Airport. So when things connect to our networks, we have to think about flight paths and how it impacts that. So we have to pass that level of complexity as well as our own internal networks.
So that's a check at the moment.
That is.
It said check. We won't talk about money, and we'll come back to that later.
And I'll also freely confess, money is also not much that I know very little about that, but I know how to spend it.
So The final component of it is the alarm fatigue promise, which we've had that promise for a long time. But do you have any actual experience of that yet?
So we've done a little bit of that work, because obviously we had the first patients who used this system, and part of what we were doing as part of our testing work is to understand how we can set alarm limits. So in the coronary care environment, I know it's the same in an ITU environment, you're really used to coming onto a ward with lots of noise, where staff are ignoring that noise from all of the monitoring systems that we have. And the problem with that is sometimes you can ignore stuff that really matters, outside of the fact that the noise pollution really annoys patients and they can't sleep at night. So alarm fatigue, particularly how it impacts staff well-being and patient safety, is a huge issue, I think. And that's something that we've been working on to try and reduce. As we do more work, particularly in different contexts, I think that's something that we'll refine further. But it's a really key issue to be tackled when these systems are implemented.
Yeah. I mean, it just makes it unusable to the point if you just have so much noise you really need to filter out. Let's talk about a little bit about what it looks like on the ward, where you work and what type of monitoring you currently have, and using there.
We've implemented this in a number of different areas. We've managed it on an acute medical unit, we've managed it on general surgical wards, and we've managed it on cardiology wards. From a cardiology ward, which is obviously the area that's probably the most monitored, clearly we've already got bedside monitors, we've got telemetry systems that we use. The real advantage of this sort of technology is how many parameters you can monitor and how mobile the patients are. On the general wards, particularly the surgical wards, that's an area where often there's not much in the way of monitoring. I'm not sure about global health systems, but if I think about our own hospital, if on a surgical ward you've got a patient with a complication, generally that means that patient or is becoming unwell, you need to move that patient to be able to give them some kind of monitoring system. And these technologies enable you to be able to do some of that monitoring remotely, because you can configure who looks at that data. It doesn't necessarily have to be that it's the surgical nurses. You can support them, for example, with a critical care outreach team. You can increase your ITU, HDU capacity by looking at workflow and how technology helps support that. And it's got to be about technology supporting workflow, not technology driving the change.
We also have the ability to take questions in the room. I'd forgotten we are actually live here. So if someone does want to join in, please get your hand up. We'll get a microphone to you. And if anyone has any comments to make about remote monitoring, any challenges they've had to date or any tips they have, that would be great too. So as a potential customer for remote monitoring, what are some of the lookouts? If I was now saying I want to make a decision to buy, with your experience so far, what do I sort of want to look at fairly early on?
So I think there are some key things that really matter from my perspective about remote monitoring technologies. So firstly, and I'm always patient-centered, is actually what it's like for patients to wear these devices and how much it impacts on their experience of care. The second issue I always think is important, and it's the other side of the patient experience coin, it's the staff experience coin. So how much can staff affect the way that technology is embedded into their workflows? How much control do we get about setting the alarms? How do we change the escalation pathways? And can staff have a really powerful voice in how these technologies are implemented? I worry about the systems and the trust level metrics as the last thing. So we talked a bit earlier, Desiree and I, about what outcome measures there are around remote monitoring technologies. And if I'm honest, there's not enough. There needs to be more work done, particularly on the patient-focused outcomes and the staff-focused outcomes. But from a trust point of view, if I take a business case up, we're always looking at things like length of stay, escalations to higher levels of care, mortality. From a patient's perspective, things like how do I experience that care? How likely am I to go home well? How likely am I going to have to come back with a similar sort of problem? Probably matter more.
Yeah.
So Zoe asked a question which I think you've just addressed. Have you had much patient and public involvement, and what's the feedback from patients? Do you want to add anything else to that? Or I think we just...
So we've done quite a lot of work about feedback from patients from our communities as well as from the hospital bed base. And I think the messages from patients are overwhelmingly positive. So a lot of people feel a sense of security from these kind of technologies. There's a huge amount of concern from our patients for the workload for our nursing colleagues. That comes through really, really strongly. And patients tend to favour things that make the workload of staff easier. From a staffing perspective, we've not seen very much feedback around people worried about the job security and whether the technology is replacing people. And I think that's, to be honest, just a reflection of the reality of where we are in terms of staffing on our general wards. Staffing is really, really difficult. So any technology that can protect the well-being of staff who currently work and reduce the stress that they get from the work that they do has got to be a good thing. But as I say, it's got to be implemented together with staff. It can't be done as a top-down, here-you-go approach. That's not going to work.
No. Well, it is not. I mean, as a nurse, it is nice to have technology that works. It gives you peace of mind. It reduces your work burden and improves workflow. And I know my patients actually, being taken care of, or I have eyes on them, with that technology. It's important. TJ, I think we have a question here in the room.
TJ again from Stony Brook, New York. So far I've heard about you describing the technology. Can you convince me, if I'm in a C-suite, why should I invest in this technology?
So, as I said, honestly speaking, I don't think the outcomes are as robust as they need to be. We know that the studies that have been done in this area are fairly, though they are heterogeneous, they use mixed methods, the outcomes aren't directly comparable. So if we look at the meta-analyses, there are some meta-analyses that point towards benefit. And we've seen, particularly in respiratory rate, for surgical populations, when we look at opioid-induced respiratory depression, there's some really strong findings emerging there. And I think for the remote monitoring research community, this has got to be an active area of research as we go forward, because there are a huge number of these options available on the market. And we know there are huge challenges in current NHS and global healthcare delivery that these technologies probably can meet. So we need to use improvement science as well as research data to really understand what the benefit for patients and staff can be.
Also, just a follow-up, and as you mentioned, there are a number of these technologies in the market, and I work in the US. Can you perhaps compare and contrast between these technologies? Much difference? The algorithm is different, or talk a little bit more about it?
So I can only talk to you about the technologies that I've got experience of using, although one of my research fellows, probably about 4 years ago, did a basic sweep of whatever was out there to have a look at. That's completely out of date now, because in the post-COVID era, there have been so many other products released to market. I think for me, I was talking to Monty about this earlier, the key measures that I think the GE technology offers over what we've already had to use is that ability to accurately measure respiratory rate and the SATS probe. Those, I think, have been really important. And COVID as an illness has taught me that as well.
Thank you.
Thank you, TJ.
We have a healthy list of Slido questions. A number of groups have been looking up motion patterns as a component of relevant science. Have you any thoughts on the potential of this?
So I think not just motion patterns, the amount of data that comes out of wearables like this is huge. There's a huge amount of potential to really understand what that data is telling us. And motion patterns, for example, have been really important in terms of our heart failure and frailty cohorts of patients that we've looked at. So I think the potential that the data from these wearables and these technologies unleashes is huge. The challenge for us is to understand how we really make a difference for patients and staff.
Whose responsibility is it to review the monitoring? Is this like a bleep, the ward cover SHO junior doctor holds? Is this for nurses to review and then pass it on to a doctor? How's the hierarchy work out?
So actually that's configurable. So it's up to each unit to decide how they want to do it. So the way we've chosen to do it, because we've talked about alarm fatigue, we've talked about sensors coming up, is to give the alert to the bay nurse, the person who's directly responsible for the care for that patient, before we escalate it up. And because it's all digital and remote, you can almost configure as many workflows as you can imagine.
Great. How good is this? Is from Alex Long. Thanks for asking your question, Alex. How good is the integration with electronic patient records? My trust uses Epic. Integration and being able to embed results would be key.
Yeah, so I'm going to be honest again, I'm no expert on interoperability, but I know that that's a key feature of the technology that is being developed. And I know from my work as a clinician, the last thing I need is 20 different systems to check for one patient.
Absolutely, integration is key. All right, does this reduce workload, or could there be an element of information overload? A different way to look at that.
Yeah, so we talked about alarms and alarm fatigue, and I think there is a real challenge if such systems are implemented poorly that actually increases the burden on staff. Now, I work on a front line on the wards. That's the last thing I need is for someone to add more work into me. But I also know how challenged our staffing is. So I think that if we do this well, this has the real potential to improve staff experience of work.
This is a great question. Do patients miss out on regular contact from nursing staff during observations? This doesn't really necessarily replace.
So we haven't replaced that, because if you think about, so one of my research fellows took some time to understand how long it took the healthcare assistant to do one set of obs. It was about 12 minutes from the beginning to the end. So there's an awful lot of time that's taken to undertake routine clinical measurement. So if we release that time back out, because we don't actually have enough staff to provide the care, it provides people potentially the opportunity to have more one-on-one care at the times that really matter.
Do you have a way of prioritising that? In other words, saying if we get this trade-off, can we redeploy that time for patient contact? Or do you think the risk is that that will just be eroded the whole time? They'll say, well, is there a way of fighting against that?
So I think my C-suite colleague is going to erode that.
How do you fight for that? Do you turn around and say, well, look, this is the quality of patient experience. We mustn't lose that time, let's protect that time.
So I think that's where the mixed methods, the data not just being the hard metrics, but the experiential and the quality metrics really come in, because that needs to be really emphasised, is what's the pluses of using this technology from a patient experience point of view. And we know, I don't need the research to tell me this, we know that patients really value particularly the nursing time they get. And we know that nurses really value, as do doctors, as do physiotherapists, dietitians, any healthcare professional really values that time to be able to devote the time that they feel is needed for the patient. So it's a win-win on both sides from an experience point of view. And yes, my C-suite colleague probably isn't going to save the pennies.
Very topical next question.
Yeah, well, we were just having a conversation about the environmental impact in the NHS.
Well, I think it's clear that we're going to be appropriately under enormous pressure to dramatically reduce our disposable, footprint.
Yeah.
And everyone's got to plan for that and mitigate that.
So are these devices reusable at the moment?
So the main parts of the system, the docking stations, etc., are reusable, but the sensors that go onto the patients aren't. And I think that's a real challenge in terms of making sure that our environmental impact is as little as possible. But as we use them and technology develops, that's how we'll be going forward, I think.
This was kind of towards our last question. Do you think that funding allocated to this technology would be better spent on increasing nursing staffing?
I'd love to do that, but we have to be able to have the bodies to recruit for right now. And if you think about how long it takes us to train a nurse to a senior level or even a junior level, and where the healthcare needs are and the level of the backlog that we're currently trying to manage, that's not an easy thing to do. So if we're looking to improve here and now, we've got to make the best use of the staff we currently have in the system.
Because on that particular debate, I think we're all clear there's a huge number of funded unfilled posts.
Yes, there are.
So it is part of the equation, isn't it?
And I'm not for one moment advocating that we use technology to replace people. I think the technology works best when people use it to improve the care that they give. But the reality is that we have vacancies we can't fill. And we need to understand how we make care safe for patients and that we protect the well-being of the staff who remain to provide that care.
So we're going to give permission to duck the question about money, because we had a chat about that earlier and you were very clear that you don't know yet. But clearly that's an important discussion for everybody to have. Absolutely. It has to be an effective and affordable solution. And I think all of our industry partners are very, very well aware of that.
Absolutely. As I say, I can spend money really well.
We'll jump to the data one coming close to the end. There's a huge amount of data being collected. Can this be used to help create more accurate risk prediction tools for post-op patients? Is that part of what you're doing?
Yes, I agree. Absolutely, yes. And part of what I'm really interested in understanding is whether we can use this sort of data to understand the time of discharge for people. So discharge is a really vulnerable point in time for any patient. But can we use the data we generate to better predict that?
So I'm going to close this section of it with another question from Zoe. Have you considered the opportunities for improved self-management and empowerment for patients, family members and carers? And we're increasingly spending time in hospital not just as a carer, but also there as a patient as one gets older. There's quite a lot of enthusiasm for self-care if people are allowed to do it, isn't there?
Absolutely. So I touched very briefly on that concept of virtual wards, which clearly requires people to self-manage much more than in a traditional ward model. So I think, as I said, there's a huge amount of potential for these kind of technologies to also redefine the healthcare professional, patient, family, carer, support network relationship.
And I think this is about, do the observations get automatically recorded? I think they do.
Yes, they do.
Onto a system. So we're going to close the Slido section there for a second. And just before we go to lunch, I want to segue for a moment, if I may, Desiree, to a conversation we were having in the green room about the enabling patients to be monitored remotely at home, and the fact that we haven't necessarily thought about all the consequences of that. You cited a few examples, which I think we should all reflect on.
Yeah, so I was talking to Monty about some of the work that I've been doing around digital inclusion. So not just digital inclusion in hospitals, but digital inclusion out in the communities. And some of the things that start to come up are things that, to be honest, even in my privileged existence, I'd never have thought about. So things like, can you afford the electricity that's needed? And at the moment, that's really topical, to power the devices and the sensors that we're asking you to use. Do you have a Wi-Fi system in your home? Can you afford the data package? What model and operating system are you using? Have you only got one email address for your family? These are sorts of things that I'd never even have considered. But as you start to ask people to use these digital technologies, they will increasingly come up.
So I'm guessing most of us in the room don't necessarily think about when we go to plug in and charge a device. We're not living in a world where we think about, I can't afford to plug it. If you're working on a meter, for example,
yeah,
that's a really important thing for us to reflect on.
And I think that's the other thing when we're talking about how we set up projects and work. Before I did this work, I'd never have considered the hardware that's needed out in the community. I was just assumed that everyone's sort of like me and the people I know, and that isn't an issue, but it is an issue. And we're going to have to find really creative ways to solve that for people.
Yeah. So, Sadia, thank you so much for joining us. In our last couple of moments, tell us, where do you think we're headed in this space? I mean, it seems like we're still a little bit farther out on actually getting the technology in and it being, available to everybody. But where do you think we're headed now?
So I think there's two elements that we're headed. I think the technology revolution post-COVID is definitely here to stay. There's no doubt about that. And I think the challenge for us as a healthcare community and bringing in our patient cohorts and our third sector organisations and patient charities is, how do we derive the best value up from that for all of us before the C-suite get involved? And then the second issue, I think, is these challenges around inclusion and data and privacy. These things are things that, if we all work together, we'll probably get an answer that works. Whereas if we're very focused on only meeting one group's needs, that's not going to work.
So before Desiree does the final wrap, we're going to give you a rousing round of applause for coming out.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.